Hello, and welcome to today's EASL Studio, your weekly hepatology broadcast news. In today's episode, we're going to discuss the recently published clinical practice guideline on liver transplantation from EASL. And it gives me great joy and pleasure to be joined by a great faculty today. I'll introduce them quickly. Professor Didier Samuel, Professor of Hepatology in Paris and Chair of the CPG. Dr. Julia Heimbach, consultant transplant surgeon at the Mayo Clinic in Rochester, and Dr. Sarwa Darwish Murad, hepatologist in Holland and a member of the scientific committee of EASL. So thanks for joining me today for this discussion about the CPG. Didier, maybe I can turn to you first. And so this CPG was an update on the previous CPG published in 2014. I think we'll discuss what's hot and what's not in the CPG compared to the field of liver transplant in general. And I'd like to start by talking about recipient selection, if I may. So from your point of view, what has changed in the last 10 years in terms of recipient selection in liver transplantation?
Thank you. Indeed, I mean this new CPG focus on what has not been discussed previously, and indeed we have some changes in the indication. Since the first important point is that hepatitis C disappear almost as an indication for since that time, and now other indications are emerging, more cancer, also patient with MASH, and also patient with very severe liver failure. And indeed, this is one of the main issue of this CPG, and I think particularly in patients with acute and chronic liver failure, and particularly those with acute and chronic liver failure type 3, and also patients with acute, severe acute alcoholic hepatitis, and patients also with acute severe autoimmune hepatitis, and also the fact that recipients are older and older at each CPGs. So these are part of the new aspect of the indication, but also some more specific issues, such as what to do with patients with very severe portopulmonary hypertension. And in the past 10 years, many new drugs have been available against portopulmonary hypertension, and patients who were considered as a contraindication for transplantation are now able to be transplanted. These are some examples of this new indication, among others, and also we will also discuss the extension of indication in patients with cancer, either primary or even so secondary sometimes. And I think this will be difficult. This will be discussed later on.
Okay, thank you. So, I mean, from what you've said, what we're doing is we're transplanting potentially older and sicker patients, given what you've described. So, Judy, if I come to you in the US, if you like, experience with ACLF, if we can start there, if we may, in terms of indications. So we'll talk about indications, and then maybe we'll talk about patient and recipient selection in a bit. So, I mean, I appreciate this, the sort of offering criteria, if you like, the selection criteria that on the waiting list for organ transplants were very different between Europe and the US traditionally. And it was always said that we transplant less sick patients in Europe compared to the US. But I think with ACLF introduction, I think we've almost leveled the playing field. Is that your experience, or am I simplifying things too much?
Well, obviously, I work in the US. I don't work in Europe, so it's hard for me to be a direct comparison. I do think the current CPG does a beautiful job of outlining, more specifically what are the red flags for patients with acute on chronic liver disease, so that it's not just, oh, we can't do these patients, but these are the specific patients that may or may not be able to be done at this specific time. In particular, there's a figure which I feel is quite a good representation, at least of our practice here, is, the patient with chronic liver disease has an insult that tips them into acute on chronic liver disease. whatever that is, and for a brief time, they may not be transplantable, but then you treat them, you get them over that one particular insult. They're still, critically ill in the ICU, high mild, but they've, we fixed whatever that was, and now there's a window that you can transplant them. So we kind of always viewed that as like a mild adjustment, and now we have the opportunity to transplant them, where you hold that score for maybe a week, and once you've gotten over whatever the critical problem is, the patient can be transplanted. And I think that's well outlined in the current CPG, and I really like that section.
Thank you. And so if I ask you to take the perspective of someone who's referring in from a different center to a transplant center like yours, what big changes do you think they have seen, and what changes will they likely see in the next 5 years? Maybe that's a slightly harsh question, but I'd like you to try to do that for me.
Yes, I want to have that crystal ball for the next 5 years. I think, it's really important, maybe also across Europe and across the United States, to recognize that patients that maybe you didn't think could be referred for transplant maybe are. In particular, we have very specific recommendations around transplant and oncologic indications, and also I think around obesity. This is an area that in the last CPG was just really kind of, I would say, it was listed really as not a good idea. And in the current one, I think there's a recognition that MASLD is the most common liver disease in the world, and we have to have a clear, structured approach. And that there are things we can do to make patients with obesity and liver disease have a good long-term outcome. So I think those things that are in evolution are definitely related to complications of metabolic liver disease and oncologic issues. Those are definitely two that have been changing and will continue to change.
Okay. So Sarwa, when I started as a transplant hepatologist, and perhaps I'll come back to the point Judy just made, but when I started as a transplant hepatologist, it was very much that figure of 70 was the magic figure, that really you would not be transplanting someone with chronic liver disease above the age of 70. You wouldn't be transplanting someone with acute liver failure above the age of 60, actually. That was the figure that was being banded around. Do you think that no longer applies? And if so, what are the criteria that as a referrer I should be thinking of if I was to refer someone for transplant?
Yeah, thank you, Ahmed. It's my pleasure to be here as well. I think that's a very important question because this CPG really marks the change of letting go of a lot of dogmas that we previously had in liver transplantation. So although the age limit was not a new novel addition to this CPG because it was already mentioned in the previous one, I do think that now it really brings home the message that it's not so much the biological at a chronological age, but it's really the biological age and how that person with that specific age is performing in terms of whether this patient has frailty or not, whether he has obesity or not, whether he has any cardiopulmonary comorbidities or not. So it went from more of the dogmatic thinking of age as a limit, or for that matter, of certain rules that we used to have, like 5-year cancer-free rules for patients who had prior malignancies. All these kind of dogmas, they've slowly disappeared over time for good reason. And now we're much more able to refine the selection of our patients and really look into, what are the real risk factors that remain for the post-transplant outcome.
So Didier, maybe I can come. Sorry, yeah. So Didier, maybe I can come to you on that. So the idea of refining the risk. I mean, and the CPG deals with this in terms of workup for transplantation. And without getting into too much of the detail, what do you think the big changes have been over the last 10 years in terms of the workup of the recipient?
I think really the big change is to